now, so, yeah, this information will be the start of the information for the final. So we'll talk through the other things as well. So, chapter 27, the big red book, Cognitive and Perceptual Dysfunctions. So, a lot of this we do, a lot of this we don't do in a sense, but it is good to recognize these because your patients will have these effects and you will have to know how to function with treating them. So there's no specific, there are some, there are no specific direct treatment things that we'll cover, like we covered P&F stuff for a lot of these, or we covered strapping or FES or things like that. There's no specific direct treatment for these patients from physical therapy, but it's integrated treatment understanding these deficits. So that's why it's so important to know these. So that's where we're headed now. So we're jumping all the way over 1055. It talks about what is cognition and perception. It says cognition can be conceived as the method used by our CNS to process information. So all the things we do. It includes knowing, understanding, awareness, judgment, and decision making. So these are the stuff that's in your frontal lobe, highlighted in your frontal lobe, and it's dealing with things like executive function and functional processing and things like that. So that's cognitive ability, cognition. So over on the right, it kind of gives some more specific definition. So it says cognition, under cognition and higher order cognition. It says cognition is the act or process of knowing, including awareness, reasoning, judgment, intuition, and memory. Executive functions are included under this, but it's even more information than just executive functioning. Things like capacity to plan, manipulative function, problem solving, error corrections, thinking abstractly, all of this comes with cognition. Cognition. Okay. Perception is the integration of sensory information that is psychologically meaningful. It's the ability to select stimuli that require attention and action, and then to integrate that into with each other and with prior information, and then finally interpret them. So you're perceiving what something is, and then you can make a decision on it. So you have perception abilities all the time. You walk outside, if you're somewhere, you look at people and you're making an examination on their perception. This person seems dangerous. Let me walk the other way. This person seems like they're going to beg me for money. Let me walk the other way. This person seems like they're a good person. I'll keep walking. This person seems like it's someone that I want to get to know. Let me talk to them. So perception, and it's further than that. You're perceiving things all the time. Driving is highly perceptual. So you're figuring out what someone's intentions should be. The person in front of you is slowing down. You're perceiving the brake lights as they're getting ready to do something. Turn left, turn right. They're just trying to cause an accident, whatever. You're perceiving that information. So you're always in the process of perception. The book tells us the terms perception and sensation are often confused. Sensation is appreciation of stimuli through organs and special senses like our eyes, ears, and our nose, the peripheral cutaneous system, and our joint receptors. Perception cannot be viewed independent of sensation. However, perception is far more complex than just recognition of pure individual sensations. So it is our abilities to process functional information. Okay, page 1056, indicators. it says cognition and perceptual deficits have to be ruled out as a cause of diminished functioning with patients. So you'll see how some of these things we'll talk about even today can affect them. These problems can be culprits in which the patient seems unable to participate fully in self-care tasks and have difficulty participating with therapy for reasons that cannot be accounted for by lack of motor inability, sensation, or comprehension or motivation. So they just can't function, even though they have the normal motor ability and some type of abilities to do, they're just not able to perceive and move forward. Top right, often patients with cognitive and perceptual difficulties display an inability to do simple tasks independently or safely, difficult in initiating or completing a task, difficult switching from one task to the next, diminished capacity to locate visually or identify objects that seems necessary for task completion. They're unable to follow sometimes simple one-step commands, except even though they have good comprehension. They make same mistakes over and over. Activities may take an ordinarily long time to complete, or they may do them impulsively. So you're trying to train them to do something, and they just can't seem to put it together. But then you're just observing them sitting there, and they do what you ask them to do just impulsively. You know, you're asking them to learn how to reach for something across their body and grab it and pick it up. They can't figure it out on their own, but you walk off for a couple of seconds and you look up and you just notice them do it on their own. Like, what the heck is that? I just asked you to do that. So it could be a cognitive perceptual dysfunction. Patients may hesitate, appear distracted and frustrated, and have poor planning. They have inattention to one side of the body, so they'll usually be folks with neglect. And so it's something that you have to deal with. Okay. So it talks about hospitalizations following brain damage. It says a significant contributor to the clinical picture of a patient who has had a CBA is the response to hospitalization. From a cognitive and perceptual perspective, when they are hospitalized with or without brain damage, the inputs imposed on their nervous system are radically different from the ones normally received. There is no variation in temperature and lighting, and familiar background noise are missing. So hospitals are monotone with everything it's doing. On the other hand, an enormous array of unfamiliar noises are present. People talking loud stuff, beeping, folks coming in all times of the night, strange and different smells, unfamiliar, unavoidable sights. Often because of motor impairments, they cannot move around and seek the escape of input. Therefore, a multiplicity of sensory inputs bombards the nervous system. Okay? So it's always interesting to think of it from that perspective, what a patient is going through once they're hospitalized, especially when you're dealing with patients who've never dealt with it. They have a lot of theories on treatment. We're going to skip through all of those because we don't go through those things. We jump straight to distinguishing between sensory and cognitive and perceptual deficits. And we start down at the bottom with visual impairments. That's where we'll spend our rest of our day today. Okay, so it says visual impairments is one of the most common forms of sensory loss affecting a patient, usually with hemiplegia, stroke, or traumatic brain, or some type of brain injury. Lesions dealing with stroke can affect the eye, the optic radiation, or visual cortex, and it affects the reception, transmission, and appreciation of visual stimuli. Visual impairments commonly encountered with folks with hemiplegia is poor eyesight, So they can lose the abilities to see well. Sometimes they can lose vision in one eye. We'll talk about that. Diplopia, that's another term for double vision. So it looks like they're seeing double of something in one eye. So diplopia is a type of double vision. I don't know if you've ever been hit in the eye and it looks like you're seeing two of something. That's diplopia. Homonymous hemianopia, that's a term you want to learn to pronounce well. Homonymous hemianopia, that's what that word is. Homonymous hemianopia. Homonymous hemianopia. So, I know you don't know what it is. You will in just a few minutes, hopefully. And damage to the visual cortex in the retina. Okay, so it says awareness of these deficits are important so as to not confuse them with visual perceptual deficiencies dealing with our patients. The critical nature of basic visual skills, acuity, oculomotor control. Acuity is seeing clearly. Oculomotor control is the abilities to move the eyes and the head independent and in conjunction with each other. So your eyes can move independent. If you fixate your eyes, so everybody fixate your eyes on one target and move your head in another direction. If your eyes can stay in that target, that's moving opposite of each other. So your eyes are moving in a different direction than your head. Most times our eyes lead our head. So our eyes are moving in a direction and our head turns. So that's moving together. So oculomotor control is the abilities to do both, independent and conjunction movement with eyes and head, and an intact visual field. And so we'll show you what visual field is here in just a second. Yeah. So it talks about Warren developed a hierarchical model. I can care less about who Warren is or the model. Their model includes visual attention, which focuses on one aspect of the environment while ignoring others. So that's something we want to see if our patients have. Do they have visual attention? Do they have visual scanning, using the eyes to follow a target? So you have your pen up and you try to get them to follow your pen with their eyes without moving their head. Just move your eyes, follow the target. That's called visual scanning. And pattern recognition. So you can either do things in patterns, have them do things, pattern on touching their fingers and trying to mimic what they see you do. Those things are things that are like pattern recognition. It says these skills, along with memory, are required to facilitate the highest level of visual skill called visual cognition. Impaired oculomotor control are common occurrences following CVA. So people lose the abilities to contract their eye muscles to function and do. So if they have a cerebral damage area, especially if it's in the occipital lobe where vision is processed, it's going to affect that control. Or if they have down near the brain stem, if they have some type of stroke or damage there, that's what cranial nerve 5 and cranial nerve 7 are. And then some of the cranial nerves can be affected by stroke that move the eye and function to move the eye. So they are common occurrences. Poor visual acuity is a frequent finding following stroke or brain injury. Diplopia or double vision is often present following brain damage. They see two of the entire environment. It's usually the result of a defective function of the extraocular muscles, so the muscles that help to move the eye, in which both eyes are used but not in conjunction with the other. Treatment consists of exercises for the eye muscle, so you're having them learn how to use their eye again, and the wearing of an eye patch on alternate eyes until the condition clears. So you want to start out with the eye patch on the unaffected eye. So let me say that again. If they have diplopia, if I have diplopia in my right eye, I'm going to put a patch on my left eye. So if I have diplopia in my right eye, I'm putting a patch on my left eye initially. Why? Why do you think I would do that? Very good. I'm forcing them to use the affected eye. And that's how you strengthen the extraocular muscles. You force them to use the eye. It's a form of constraint-induced movement therapy. We don't think of it that way, but that's what it is. So you're blocking out one eye and forcing them to use the eye that's weak. And the more they use it, the stronger it becomes, and the more the diplopia goes away. So it's a type of constraint-induced movement therapy. So if the condition does not clear, an optometrist may recommend the use of prisms. That's way above our head. They need visual therapy, visual rehab. There are some people that do that. Transparently, my wife has actually gone back to school to learn that from an OT standpoint. And it's stuff that they're learning is way out there. But it's really cool for the patients that need it. Way over my head. So not something we do. So that's something, if you're noticing it in your patients, they're continually complaining, refer them back to the supervising PT, and then they can refer them to either a physician or get someone in to look at it. But that's out of our league to treat. We don't treat prism deficits and things like that. Okay, visual field deficit is probably the most common deficit affecting patients with hemiplegia, and it occurs most often following damage to the middle cerebral artery. And so, put a pause there, and then we'll talk about visual field deficits and how we see. So that's what we want to talk about. So, how do we see? So, the eyes are very strategic and very specific in how they see. So let me say that to start off with. So let's start with, let's see here. This is a good picture to start with. So our eyes themselves, I guess we'll call them our eyeballs, will pick up information from the environment. Whatever we're seeing, it comes in from the environment, and then it's transmitted from the eyeball through the retinas, and then into the optic nerve. So the retina is inside of the eye. That helps to process information, and then it goes from there to the optic nerve. It goes from the optic nerve in through the optic chiasm, where it's going, some of vision is going to cross to the opposite side, and then it's transmitted to the optic tract. It transmits from the optic tract to the optic radiations, and then finally to the occipital lobe to be processed. So, let me say that again, because it's going to go deeper, even further than that. So, vision, anything you're seeing, whatever your eyes are seeing right now, this picture should be what your eyes should be seeing, and you should be paying attention to what I'm saying. So, vision, this picture that you're now seeing is going to enter the eye, is then processed by the retina, and then transmitted into the optic nerve. Just like we have nerves that transmit signals to our muscles, we have nerves that transmit information visually to the parts of our brain that process it. Optic nerve. Then parts of our vision are going to cross in this place called the optic chiasm. There's parts of visions that will cross in the chiasm. Once they cross, they are then picked up by the optic tract. Just like we have corticospinal tract, anterolateral spinal thalamic tract, dorsal column, medial lemniscus tract, we have an optic tract that picks up information. The tract then picks it up, transmits it through the optic radiations, and then finally into the occipital lobe, where the primary visual cortex is housed. Okay? So that's the basic information of how information travels from our eyeballs into our occipital lobe, our primary visual cortex. So what we're looking at is processed. So our brain processes it. Okay? So this is another picture of it here. You can see it. So eyes, retinas, optic nerve, optic chiasm, optic tract. It'll go through the optic radiations and then to the occipital nerve. Okay? So there are different parts of our eyes that help to transmit information from our retina into our optic nerve. So we have rods and cones that help to transmit information from our retina into our optic nerve. So inside of the eye, we have things called rods and cones that help to transmit information from our retina into our optic nerve. Why is that important? Because rods and cones are specific to what they are seeing. So, this is where it gets fun. All right, people, hang on to your faith. We're about to have some fun. Let's talk about how we see. So, these will be our eyeballs. We're good to go there, so we'll call this our left. This will be our right eyeball. We're good there. Okay, so now I'm going to draw this like this, this like this. I'm going to draw this like this like these, just like that. This will then be our occipital lobe. So let me draw a brain here, and we're back here in the occipital lobe. Okay, so information ultimately is going to travel from our eyeballs to our occipital lobe. Okay, so let's watch the video, then we'll teach it. Let's have some fun.
Hello, in this video we're going to look at the pathway of vision, and we also will look at what happens when there are lesions that occur along this pathway and how it affects our vision. So here is the occipital lobe, the eyeball, optic nerve, optic chiasm, lateral geniculate body, and optic tract, also known as the genico-caprine tract. Here are our visual fields. We are looking at this whole visual pathway, from the top. So the blue nerve on the left side here will pick up the left nasal field and will carry this visual information to the lateral geniculate body, where it will synapse with another nerve. And this other nerve will then carry this information to the occipital lobe. The blue nerve on the right eyeball here will capture images from the right temporal field and will carry this information down the optic nerve and will cross over at the optic chiasm and synapse with the neurons of the left lateral geniculate body. The nerves will then carry the information to the occipital lobe. This orange optic nerve on the left eyeball here will capture images from the left temporal visual field and cross over at the optic chiasm and synapse at the right lateral geniculate body, where it will relay the information to the occipital, to the optic tract, which then will bring it to the occipital lobe. Now, similarly, the orange optic nerve of the right eye will capture the image from the right nasal visual field. It will not cross over, but will remain, will relay this information, down to the lateral geniculate body, and then it will synapse with other nerves along the optic tract, and then down to the occipital lobe. I hope this pathway makes sense. Now that we have an overview.
Okay, so let's review what he said so that it makes sense to you. Because I don't need you lost there. So let's review. So information is received into our eyeball and then is processed by our retinas. So if you ever hear people say, I have a detached retina, it's going to affect the way that they see. So information comes into the eyeball, then goes to the retina. So we'll say this is vision. So we, number one, eyeball, or the ball of the eye. Number two, retina. Okay, then number three is going to be transmitted to rods and cones of the retina. So the retina has things called rods and cones. And the rods and cones pick up specific components of vision. So rods and cones pick up specific components of vision. So let's get two different colors here so that we can make this make sense. Let's get some colors y'all can see. Okay, blue and purple almost look the same. Somebody may have trouble. Let's use them. Okay, so we have lateral rods and cones, and we have medial rods and cones. So lateral, we call those temporal. And then medial, we call those nasal. So if we are looking at it, this is our person, our nose is right here in the middle, those are our eyeballs, and then we're looking out and seeing things that are specific. Okay? Nobody lost there. Okay, so what are the rods and cones responsible for? Lateral rods and cones are always responsible for seeing nasally. They're going to see inside. So lateral rods and cones are going to see nasally. They're going to see across. They're seeing this way. So both rods and cones are seeing across. So they're lateral in our eyes. They're responsible for seeing across. So they're going to see nasally. So when you're looking here at this picture here, the left eye red is a lateral that's seeing nasal. The blue right eye is lateral and it's responsible for seeing nasally going back across. So lateral rods and cones are responsible for seeing nasally. Once they pick up the information from the retina or pick up the visual information they're supposed to see, they're going to then take that information from the rods and cones and then transmit it down to the optic nerve. So number 4 is optic nerve. Number 4, well, let me write it here because it's going to change with the different color. So number 4 here is going to then go to the optic nerve. Okay, so optic nerve is right in here. Okay? Then they're going to just turn and shift their information going into the optic tract. So number 5 for this one is optic tract. Then finally, number 6, they'll go into optic radiations. And then finally, number 7, the occipital lobe, which is the primary visual cortex. So we talked about primary motor cortex, we talked about primary somatosensory cortex. Now we have a primary visual cortex. So it's going to go through the optic nerve. So this is optic nerve. This will be the optic tract. Somewhere down here will be optic radiations. And then finally, it's going to go to the occipital lobe. So our lateral rods and cones are going to be responsible for seeing nasally and then transmitting information from the optic to the optic nerve, then through the optic tract, optic radiations, and then finally to the occipital lobe into the primary visual cortex. So nasal vision is seeing that way. Okay, but that's just only one side of vision, because you don't just have nasal vision. And I'll prove it to you. Take your hands, put your fingers like this on the side of your head, let the heel of your hand rest right there on your temples, and now, what do you see lateral? If you try to look lateral, don't move your head. If you try to look lateral, what do you see? Your hands. That's right. You don't see a visual picture. So you have more vision than just nasal vision. You have peripheral vision. We agree? You can see a panoramic view. None of you are just looking through a pinhole like this. You're able to see peripheral. So how do we get peripheral vision? I'm glad you asked. So now, peripheral vision, come on down. You want to come teach this part? Okay, so rods and cones on the nasal aspect of the eye are going to see peripherally. They're going to see laterally. So their job is to see lateral. They give me the wide peripheral vision that I see. So when you look straight ahead, you're still able to see stuff all the way out here. So matter of fact, take your fingers, stretch them out wide as you can, point your thumbs toward the ceiling, and start walking your fingers in until you can see your fingers. That's the length of your peripheral vision. So that's how wide you can see peripherally. You're able to see that. So, see that? So you have that. Now, they do something totally different. They don't follow the same rules. They're going to transmit information from the rods and cones to the optic nerve. Yes, just like number 4. So we're going to go to the optic nerve, just like number 4. Yes. But instead of just going to the optic tract, like they are going to do, they are going to cross here in the optic chiasm. So they cross in the optic chiasm. So temporal vision crosses in the optic chiasm. Temporal vision crosses in the optic chiasm. Again, temporal vision crosses in the optic chiasm. So let's show you this again. So that's going to be the optic chiasm right here in the middle.
Would that not be nasal vision?
No,
On the board.
because they see temporally. The rods and cones are on the nasal side, but they're seeing temporally. Does that make sense?
Then why is the
It's like, that's the color
lateral
though, like it's the color.
temporal and then the medial nasal?
That's what I'm thinking.
Now I'm getting
Okay, so lateral mean rods and cones.
the lateral rods and cones.
See temporally or nasally. So that's what this is saying. The lateral, let me put rods and cones.
Okay,
So
so it's
y'all
not lateral vision, it's temporal.
Yeah.
The medium will see out. The lateral will see.
Yeah. So rods and cones in the eye are then responsible for some type of vision that's different. So lateral rods and cones are going to see nasally or temporally. So, yeah. So they're going to see temporal. Well, hang on. Yeah, hang on. I see what y'all saying. Yeah, they're called temporal, but they see nasal.
Okay.
Does that make sense? So when people refer to them, they don't call them lateral rods and cones. They'll just say temporal or lateral. And they're responsible for seeing nasally. Whereas medial rods and cones are called nasal rods and cones, but they're responsible for seeing peripherally. Yeah. Don't get lost there. They're responsible for seeing peripheral. So the inside nasal rods and cones, remember this is our nose, so these are the ones closest to the nose, they're going to see out peripherally. Then they're going to go to the optic tract. I mean, they're going to go to the optic nerve just like the other ones, but then they have a 4B where they're going to then cross in the optic chiasm. They're going to cross in the chiasm. So 4B is crossing the chiasm. Let me make this a smaller file. So that's 4B. And then it's going to follow the same track as everything else from 5 on down. Everything else is the exact same. So they're going to go through the optic tract, the optic radiation, and then into the occipital lobe. Same way.
And they still go through the optic nerve too.
Mm-hmm. Yeah. So it's going to follow all of this. So let me put a check. So everywhere there's a check mark, the purple will do, just like the orange. The only difference is the nasal ones are going to cross in the optic chiasm. And now, because of the crossing, I have blended vision in my eye. So in the optic tract, it's going to carry nasal vision of my left eye, but it's going to carry peripheral vision of my right eye. So that gives me what's called visual field. So it looks like this. So that's what the left optic tract is carrying. So if you take your hands, put it sideways like this, take this hand, put it sideways like that, that's the visual field I'm able to see in my optic tract. Same thing, if I go this way with my right eye, my visual field is this. So there are different visual components, and the components come together to form a visual field. So my field of vision is what you're seeing here in this first picture. That's a visual field. So my lateral rods and cones of my left eye will see nasally, they're seeing across, and they're going to mix with the lateral, they're going to mix with the, hang on. So my lateral rods and cones of my left eye are going to see nasally. They're going to mix with the medial rods and cone of my right eye, which will see nasally, and that gives me a visual field. So you're blending in a field. So that's why the two reds will come together inside of the optic tract. So now I have a visual field. So I have a lateral and a temporal. Come on down, good sir. I promise you they're tired of me. Listen, it's something crazy all the time. So that's a visual field. All right, so I'll send the video, master that. Take 10, get yourselves some water, get yourselves a break. Then y'all will start back with Mr. Chris. Have some fun. No, they're going to have a ball. They're going to have a ball. Come on down. You're up here, sir. We'll move all of our junk out of the way. We yield to your wisdom. Let me throw all this. I can stack this and move junk. I can erase the board if you want to write on the board.
I shouldn't need that.
Sure.
I've got a jump drive with mine.
Come on around.
Go to the
How you
night
doing,
today?
sir? I'm doing great. Tommy Winston.
Sam's the Meridian office here, so I drug him along.
I met you a
I
while.
was like, it's been a long time. You're in there with Briscoe, so I have to pray daily for you.
Yeah.
I do. I know how fun Briscoe is. He's a fun guy. We do love Briscoe. What project is he working on now?
That's a good question. He had to hang back and wait on a patient of ours, and he usually comes in only when something's broke. So
So something's probably broken.
something probably broke on that leg.